Assalamu alaikum dear doctors. In this video I am discussing a video station. So first we will watch the video, then I will discuss what type of question we are expecting from this video station. It is also an important recall video.
You are not supposed to send this child to the surgeon unless and until the electrolytes are correct. Yeah. Never give this child to surgeon. Fix them. Okay, fix them. Fix. You are recording, no? You are recording. So it's everybody, no?
First question is that what I observed in this video, I can see a neonate who is lying in the bed, probably hospital setting, and their abdomen is showing a visible intestinal peristalsis in the epigastrium is moving from left to right. So my most top probable diagnosis is pyloric stenosis. Discussing about the pyloric stenosis. Boys are more affected than the girls, that is ages 2 to 10 weeks of age runs in families. The differential diagnosis of pyloric stenosis we can say volvulus, intestinal obstruction, intestinal malrotation, gastroesophageal reflux disease, cosmic protein intolerance, gastroenteritis with dehydration, congenital adrenal hyperplasia if vomiting in the opening statement. Description is that important to comment on the mass olive shape. It is direction of the movement from left to right and hydration status of the child. So olive shape mass we find and movement is direction left to right and hydration status of the child. Next question, what history you would like to ask in this patient? So I would like to ask the history. Number 1, onset, course and duration, what increase and what decrease, usually gradually and progressively. Number 2, vomiting is forceful, hitting the wall, onset of the vomiting if immediately after meals, color of the vomitus equal non-bilious if green, so intestinal obstruction and its content. So bilious vomiting, then we can go for obstructions. Non-bilious vomiting occur in pyloric stenosis. We know that there is hyperplasia occur, that's why. Now, vomits after each feed. Is he hungry after feeds? Weight and height and comment on growth chart. Number of the diapers changed per day. Any blood in the stool. Type of milk and its amount in each feed and number of feeds per day. Family history of similar condition as it is a multifactorial inheritance and more in males. Male equal female ratio is that 4:1. And antibiotic taken in neonatal period. Erythromycin or not. Now examination. What examination I would like to do? I'd like to do for pyloric stenosis, first ABCD, airway, breathing, circulations, ACs, hydration status, then shrunken enterofontanally, skin turgor, shrunken eyes, dryness of the mouth, no tears. These are the hydration status we check. Then feed test and check response, general examination for any pigmentation for congenital adrenal hyperplasia. Investigation, what investigation we do for pyloric stenosis? Lab we do the full blood count, ABG, urea and electrolyte. We find hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis. And imagine we do the ultrasound of the abdomen. Length is more than 17 mm, thickness is more than 4 mm. X-ray with barium, that is sting sign or mushroom sign. Management including admission, stop the oral intake, insert NG tube and do aspiration hourly and test feed. IV fluids, if metabolic alkalosis 150 ml per kg per day of 0.9% sodium chloride plus 5% dextrose plus 10 millimole potassium chloride and repeat ABG every 12 hours. If no metabolic alkalosis, 120 ml per kg per day of 0.9 sodium chloride plus 5% dextrose or 10 millimole potassium chloride and ABG daily. Aim to fully correct the fluid and electrolytes within 48 hours. That is chloride more than 100 millimole per liter, bicarbonate less than 28 millimole per liter and potassium more than 3.5 millimole per liter. Once full correction is achieved, convert to maintenance fluid, that is 100 ml per kg per day. Surgery after correction of the dehydration and alkalosis, Ramstad's pyloromyotomy. Open surgery of the laparoscopic pyloromyotomy. So this is the surgery name. Feeding restarted after 6 to 12 hours and discharge within 48 hours if the patient is stable and tolerating feeds. Good prognosis. Team. Which team will involve in pyloric stenosis? That is consultant, pediatrician, gastroenterologist, pediatric surgeon and anesthesia. So this is all about pyloric stenosis video station. Please do subscribe and share. MRC PCH with Dr. Amma Chaudhuri. Thank you.